we will start with this. We'll look into the hormonal evaluation of an IVF cycle. Now here we are looking at an antagonist cycle and how we should do evaluation. Actually, this was a question asked, and that's why me and Sharyu prepared this presentation on, is endocrinological monitoring of an IVF cycle a must? That was a question asked. Can we just go by doing minimalistic monitoring, go more by the ultrasounds? You could be still right. If you listen to a few consultants, they would say, why do so many tests? I'm okay doing ultrasound monitoring and taking the decisions. You would be right most of the time. But we forget one fact. If we are debating what is good, what is bad, how will you increase your yield of oocytes, what will give you a better embryo quality, all those things which we have learned in reproductive medicine is the result of the hormonal evaluation of the cycles. So I prefer doing hormonal evaluation to the fullest in all our cycles, because if you want to audit yourself, you want to audit your clinical key performance indicators, then if you don't have hormonal evaluation, you will not be able to audit KPIs, and more likely you stand a doctor to be blamed for a poor result because you don't have substantiating hormonal reports. If you have hormonal reports, you can put the onus onto the client. Well, I was not to be blamed. The client responded in this particular fashion, or she is a low responder, etc., etc. Anyway, let's go through. This is a paper in 2023 about ovarian stimulation and hormone monitoring to be done. 98.9% reported using ultrasound to monitor ovarian stimulation cycles, and hormonal monitoring was used by nearly about 80%. 87% of gynecologists during ovarian stimulation, with 61.7% adjusting the dose based on hormonal levels. Just because you are not seeing a good recruitment, you need a substantiating hormonal levels to tell you whether you want to cancel the cycle up or you want to add something up there. Like you go for 5 days. At the end of 5 days, your E2 level is less than 100. That means whatever dose you gave has never touched the FSS threshold of this particular lady. You better cancel that cycle up and go with a higher dose. If you want to increase the dose, then you have to explain, well, today is the first day of stimulation. I'll go for another 12 days from today. But similarly, do you want to cancel a cycle which is not doing well? Let's say it's a poor responder, and the criteria are set. Like suppose your day 6 E2 level is less than 180 picograms, you can abandon the cycle and go for the next stimulation cycle. So all those decisions are based on hormonal evaluation. Estradiol is the most frequently monitored in all visits and was used by almost 2/3 of the population to estimate ovarian hyperstimulation syndrome, and dose modifications, additional LH to be added, etc., all was based on hormonal evaluation. So the real world scenario is, this is a survey report, definitely that most of us do hormonal evaluation of our IVF cycles. So should you do USG alone or this? Is there a consensus on IVF clinics that we should do hormonal evaluation? Suppose you have a hypoc where you're stimulating. Now hypoc is so difficult to monitor. You will have to use hormones to know whether the follicle is doing well. And because they will take a long time for the follicle to generate well and go ahead. So hormonal monitoring is going to be very, very important. Extreme low reserve stimulations. And these are the patients who their LH escapes very fast, or you don't know the follicle which you're seeing is an atretic follicle you are recovered, or it is actually an AFC which is growing up. So hormonal monitoring becomes a must. And suppose you land up adding an antagonist with a follicle looking good but hormonally performing bad, even that follicle may stop growing. So we require a hormonal monitoring. Criteria for cycle cancellation. You can't say to the client that, well, you're not stimulated, well, that's why I'm cancelling. You have to substantiate it with hormonal reports, and then only you will say your cycle cancellation. And analyzing Posidon 1. The Posidon 1, suppose you have a sudden hyporesponder where you've got 6 oocytes when you're expecting about 12, then you have to evaluate what could have gone wrong. So without a hormonal evaluation profile available of that particular cycle, very difficult to make a decision what you will change in the next cycle. So hormonal monitoring, according to me, is a must in every IVF cycle. So we will go through all these stages and how we will do hormonal monitoring of each stage. So day 2. So this is the start of the stimulation. The start of the stimulation, many of us would do on day 2 of a menstrual cycle, but in our practice, I do random start. So if you're starting day 2, you're doing a scan, the scan is showing a quiet ovary, endometrium is thin, everything all else is normal. There is no cyst or residual follicle. Really, there is no need to embark onto any hormonal test. You can just start off with the stimulation which you have decided. Assuming that you have already evaluated the IVF patient earlier, you already have her FSH, LH, AMH all tested, earlier reports are available with you. On day 2, if you realize that her FSH, LH is never done, then that is the time to complete that test. So otherwise, on day 2 of a cycle, if you're starting a stimulation, no reason to do a particular test if you're giving an antagonist protocol. Okay, we'll just go ahead.
So white ovary means the follicle at 8 millimeter.
There is no follicle beyond 10 millimeter. Quiet ovary means that. Huh? Okay. Yeah, I think, okay, what she says is correct. So I'll just describe you how a standard antagonist cycle goes with us. I'll just describe you that, and then we will go to the presentation. Secondly, the client will come on day 2. On day 2 of the cycle, let's say I'm not doing random start here. The patient can come on day 2 of the menses. She is already showing me the reports of FSH, LH, AMH already there. All the pre-operative evaluation tests have been done with her. She's been explained about the procedure, etc. And we just look at the BMI, age, and the AMH, AFC, and start the stimulation. Do we do a scan? Yes, we do a scan to find out quiet ovary. We'll have a relook at the antral follicle count so we can know our follicle output rate, etc. We look at all those factors, and then we start the stimulation. Generally, I prefer, as I told you earlier also, a stimulation of 300 IU is standard. I never go less than 300 IU. And my stimulation is generally REC-FSH and HMG combination. So I will start either Gonal-F or Numonor 150 IU or Menopure or routine HMG of 150 IU. If the client is obese, so my cutoff is 70 kg. If the client is beyond 70 kg, then I would add either Gonal-F 300 or HMG 300, depending upon the ovarian reserve. I take that decision up. Lady with a low reserve, I would add Gonal-F more. A lady with like a PCOS, I will increase my HMG more. That's how I alter it. So my dose will be 450 IU in all the women who are beyond 70 kg. There will be women who will come, who will be thin, who will be, in a sense, not 70 kg. They are normal ovarian reserve. In spite of that, I may put a dose of 450 IU, provided, like this lady, I'm going to go for a, let's say, PGTA. That they have failed earlier, or some reason or other we are going for PGTA. PGTA is all about accumulating as many blastocysts as possible, so you can select out the euploid blast and transfer. So my doses will be 450. So I'm not hesitant to put my dose to 300 to 450. 600 are rare, very, very rare situations I would go 600. Otherwise, it's always 300 to 450 and always a combination. If you ask me, which kind of clients need a HMG push, and my take is polycystic ovary syndrome. They need HMG push because you want to moderate your stimulation. You don't want small follicles to grow a lot. You don't want explosion of the stimulation process. And if you ask me who needs REC-FSH, it is the poor ovarian reserve who needs REC-FSH. It is an old age patient who needs REC-FSH. But REC-FSH alone is not adequate there. In poor ovarian reserve and advanced stage, you have androgen deficiencies. You need to supplement them with androgen, and that's why you need an LH activity, and HMG is going to be a must. Okay, so uniformly, if you think, if you're giving 150 of Gonal-F Menopure to everybody, probably you don't have to think twice, and you will be right in most of your cases. So on day 2, I will start with this stimulation, and then the client sees me after 5 days of stimulation. On day 6 of stimulation, I see this client. So what do I expect? I expect a few follicles to be recruited. So when I do a scan, I want a few follicles to be going beyond 10 millimeter. Most of the patients will have it. In women with advanced stage, in women with poor ovarian reserve, instead of 10, the follicle could be even 12 and 14 millimeter. These women have low AMH, so there is low resistance to stimulation. So the follicles will respond better, and you will have 12, 13 millimeter follicle even on day 6. Otherwise, most of them will be 9, 10 millimeter. In PCOS, probably no follicle is 10 millimeter. Follicles will be between 8 to 9 millimeter. And it is still recruited follicle, because on day 2, I could have seen all follicles less than 6 millimeter. So PCOS will be slow to respond because they have high AMH. AMH again an FSH inhibitor. Not inhibitor means resistance is there. So they will slowly keep growing. Day 6, what investigations I do? I would prefer doing an estradiol and LH level, and I want a normal LH to on that day. So what has happened in the meantime, when you started on your stimulation to this, that you in FSH level went up very high. The follicles started developing, and because of FSH going up, the exogenous FSH, the follicles started developing. The granulosa cells of these follicles, from diameter of 4 to 6 to about 12 millimeter, secrete a factor called gonadotrophin surge attenuating factor, GNSAF, that is secreted. And this factor takes the LH down, and this does not allow premature luteinization. So don't expect a follicle to have premature luteinization when the follicle is between premature luteal surge, I would say, LH surge, is till about 12 millimeter, because gonadotrophin surge attenuating factor is there. So if you look at the LH levels on day 2 and LH levels on day 6, the day 6 LH level in most of the patients will be lower than the basal LH level. Okay, this is because of GNSAF. Now, this GNSAF comes from the granulosa cell. The number of, or the amount of granulosa cell in every follicle at every age is not the same. The follicle may look same, but granulosa cell population will differ. So in women who are older women, the age beyond 38, 39, low reserve women, the number of granulosa cell layers will be less, maybe 4 or 6 layers. Okay, while a normal lady will have about 8 to 12 layers. With the amount of granulosa cell layers less, the GNSAF is less. So in these women, the older women, or women with very bad diminished ovarian reserve, the LH, some of the patients, LH will not go down on day 6. The LH may still be higher. Okay, that will be noticed in this particular group. So these are the women who are at risk of having a premature LH surge more, because their LH is not controlled by GNSF. Exactly opposite is in polycystic ovary. Polycystic ovary, large number of granulosa cells, because ovarian follicles are large number, so GNSF is very high. But the problem with polycystic ovary is the E2 is also very high. The estradiol level also goes up. Like day 6 estradiol level in a normal patient will be anything around 200 to 400, while a PCOS could be 600 to 1200. So there is a competition between estrogen high level telling the pituitary to surge the LH, and GNSF telling the pituitaries not to do that. So that fine tuning balance we don't know about. So in PCOS also we will start antagonists. So on day 6, this is what has happened. So what has happened to LH? LH has generally come down. I told you in which patient it may not come down. E2, depending upon the response, the E2s will be there. Now, will you start antagonists? So there are 2 ways of doing it. I used to start fixed dose antagonists, fixed day antagonists. So all my patients would go on day 6 with antagonist. Now, why? The question is why. So we have 3 kinds of patients: normal responders, PCOS, and poor responders. In normal responders, you would have good number of follicles going beyond 10 millimeter on day 6. The E2s will be 300 and more, and E2 is going to increase every day. And Spirov said that the E2 is beyond 200 picogram. For 50 hours, there will be an LH surge. So E2 is already day 6 with 300 is there. So it is going to go up because your exogenous stimulation is there. So I am at risk of premature LH surge, and I would add antagonist. For poor ovarian reserve patients or advanced age patient, there are less granular cells, GNSF is low, so premature LH surge is more likely to occur. Hence, I will add fixed day antagonist even in poor ovarian reserve women. And in a PCOS woman, well, the follicle is not even 10 millimeter, it could be 8 and 9 millimeter, but the E2 level is very high. And this E2 can have a LH surge. Or not only that, the follicle of 4 to 6 millimeter has more LH receptors compared to any other lady, because she's a polycystic ovary patient. In polycystic ovarian disease, one of the reasons of poor response is the LH receptor develops very fast in 4 to 6 millimeter. Well, otherwise the LH receptor 50-50, I say it will be beyond 8 millimeter. Because of this, and once the LH receptor is satisfied, cyclic AMP pathway is stimulated and follicular arrest takes place. There is no proper growth of the follicle. So even in that situation, I would like to put my antagonist on day 6. You understood? In real world scenario, poor, normal or high responder, all 3 demand a fixed day antagonist. So initially when they did a study, a systematic review was published on fixed day antagonist and flexi antagonist. Okay, so they could not define flexi antagonist firstly. So what is the definition of flexi antagonist? So you say if the follicle is 14 millimeter, I will add antagonist. That was the first definition. But in poor ovarian reserve patients, advanced age patients, at 12 millimeter there is a surge. If you wait for 14, a few of them will rupture on their own. You got it? So that definition was not holding true. When the real world scenario is that your advanced age women are more in your practice. So the next fractionated definition came that you do an LH E2 follicular size on day 6. If the LH is beyond 10, if the follicle sizes is beyond 12 millimeter, or the the E2 level is beyond 300 picogram, you add antagonist. Any one of them positive. Any one of these things positive, you add an antagonist. E2 beyond 300, LH beyond 10, and a follicle size beyond 12 millimeter. Any one of them positive, you add an antagonist. So the flexi, so they practice flexi onto these protocol or this protocol, and over a period of time, they realized that fixed antagonist, the systematic review said the fixed antagonist has a better result, a better control over the cycle, better yield and live birth rate, and that's why the whole world accepted fixed antagonist. You understood? That's the way we did. Now this was a time till now we were considering LH as a bad hormone, and we had a lot of misconception in our mind that patients who have high LH, and LH is bad, on top of that you're giving HMG. So we thought LH will accumulate, and accumulated LH will be still worst. And that's why we always consider LH as a foe, not a friend. Okay. But then, when they started thinking theoretically, the kind of LH activity in the HMG molecule will not last beyond 12 hours. So it is no way LH can accumulate in the blood and your serum LH will go up because you are using an HMG preparation. So then that was refuted, that HMG adds to an LH activity. So slowly everybody thought about this. And nowadays we learn a different concept, and which I will visit when we do this up, that we would like to maintain a good LH activity. I'll come to that later. So day 6 I will do an E2 level, LH level. I'll put a fixed antagonist and the client goes up. Then I see them directly on day 10. I don't see them in between day 10 or sometimes even day 11 I see them because there's no need to monitor them closely. Day 10 or day 11 when they come to me, I have a look at the follicle, then I measure the number of follicles and sizes. I see how many is the majority of the herd crossing beyond 17 millimeter. If that is possible, then I say, well, this is my trigger day. Or I wait for 1 or 2 days. I may wait sometime for 14th day, 15th day also, till majority of the follicles are crossing beyond 17 millimeter. If I get anxious, like 2-3 follicles are already 22 millimeter, 23 millimeter, I may repeat a LH level again. So in spite of your antagonist, if the LH is still keeping high, LH is 8 and more, I may double my dose of antagonist. But remember, this LH must be done in the morning hours before the lady takes antagonist injection. The LH could be high, but you are doing an LH level after 2 to 3 hours after she has taken an antagonist injection, and the LH report comes 1 and 2, you feel happy, but actually that is not. She is maintaining a high LH. LH is escaping, but you have not picked it up because you did an LH level. So all levels like estrogen, progesterone, everything should be done before the antagonist dose in the morning hours only. Okay, then that will give you a diurnal variation, everything stands corrected. So on the final day of the day trigger, my decision to give a trigger is by ultrasound parameters. I will do an E2 level, LH level, progesterone level, and FSH level. Now, why do I do that? I do it for my academic interest. E2 level is going to tell me how strongly the stimulation has gone up. So, a proportional follicles I'll get. Suppose the E2 comes 5,000, I get 6 eggs. I know I've done some mistake or something has gone wrong somewhere. LH, if it is very, very low, I get worried a bit. It's 0.5 LH on the day of trigger. I'm worried whether I'll get a good response. Because I believe in maintaining a good tone. But everything is gone now. I can't change now anything. So the story is ended anyway. FSH I told you yesterday that I need an FSH beyond 17 MIU, 222 or whatever high, because it is my counseling tool of poor responder that I did not go wrong. I gave adequate dose and FSH. So that's a good counseling tool for me. Secondly, this FSH also tells me what adjustment I need to do in the next cycle, because many times I will be doing 2 or 3 stimulations for a patient to accumulate blastocyst or PGTA cycle or even poor ovarian reserve. I always keep telling her, yesterday's client you were describing, 25-year-old with AMH of 0.5. I will definitely tell her, please let us go for 2-3 stimulation cycles so that we get good number of blastocysts and then do an embryo transfer to them. Okay, so then that FSH becomes a good counseling tool for me. We always give dual trigger to all our patients of normal responders, all patients of poor ovarian reserve, everybody goes on a dual trigger. Our dual trigger is 250 microgram of HCG and 3 ml of Leupride. So I purchase Leupride 4 ml equal to 4 milligram. I give 1.5 ml subcutaneous on either buttocks and with 250 microgram of recombinant HCG. I don't use decapeptyl, but you can use decapeptyl. Wong et al. Did a study of dose-finding studies of different kinds of GnRH agonist injection. They said there is no difference. You can use 0.2, 0.3, 0.4. Whatever you use, it doesn't make much of a difference. And post-trigger, as soon as the trigger is given, the client is told the very next day to take Brufen tablet. So I give Brufen to everybody. Post-trigger. The next day, they take Brufen 400 milligram 3 times a day with pantoprazole or rabeprazole, they take it. This is to avoid any early ovulation. Then the patient comes NBM at about 35 hours after consenting, all signatures, everything done. Then at 35 hours, a proper pickup will be done for that client. This is the way I look into this. If I am giving Leupride alone as a trigger, Leuprolide alone as a trigger, then we always measure a trigger. And Dr. Shariu will tell you on a trigger lecture how different kinds of trigger we give and how monitoring and what is the importance of all these things. You understood how we do our antagonist cycle? Okay, a note on pre-treatment. I think pre-treatment I'll address here itself. Okay, knowing this way and understanding we do an antagonist cycle, let's now visit this particular presentation. Now don't get complex, this is not complex at all, very easy to understand. So this is your ovulation, the red line is an ovulation day, okay, and this red line is a mid-luteal line, you can say. So from day 1 to 14, whenever you start a stimulation, what will be on day 1? Your E2 will be less than 60 picogram, which you just had menstruation, and FSH-LH will be normal, but we don't measure this. But you will have women who have taken OC pills as pre-treatment, or they might have taken Leuprolide depot injections prior because of endometrioma surgery. In that case, it's nothing wrong in measuring these up. Then we will start a stimulation. So you'll have follicles here. And what happens on day 6? E2 will be high, FSH will be high. Now, this is not stimulation day, by the way. This is a natural cycle day. This is a natural cycle. This I'm depicting your natural cycle. So where all you can start your stimulation. You can definitely start a stimulation on day 2. You'll have follicles lined up, AFCs there you can start off. As you grow here, a few of the follicles have become dominant. So you'll have more follicles of 8 to 10 millimeter. In natural cycle, I am not stimulated yet. So your LHFS is both is high because this is early follicular phase. This red line, this is ovulation. So this is I'm confusing you. This is early follicle, this is late follicular phase. LH-FSH will be still higher and E2 is high because FSH-LH is still secreted. The FSH though is coming down compared to the first phase, a little less, but it will be still higher than normal. Then there will be ovulation. Post-ovulation, you will have an early luteal phase, you will have a natural corpus luteum. Corpus luteum is secreting progesterone. Progesterone high, so GnRH pulsatility is low. FSH will be normal and LH will be predominantly present here in this too. And of the follicles which are seen here, a few follicles are antral follicle counts. The few follicles, the big ones, are actually atretic follicles which developed here and they did not become a dominant one. So they are persisting as atretic. When you go to the late luteal phase, the atretic follicles have disappeared probably, all of them. And your corpus luteum is also coming down. So your progesterone is down, estrogen is down, FSH-LH is low, and now it's going to start rising because 3 or 4 days prior to the expected menses, the FSH starts rising, I told you yesterday. So, and all the follicles will be lined up very well. So for random start, this diagram understanding is very important. So you can start the patient. If the patient has come from US and as soon as she arrives in a cabin, she enters you, doctor, where should I keep my money? And she puts 2 lakh rupees in front of you. And she said, okay, doctor, you start my stimulation. And you say slurp. And then you start the stimulation. So you must know what phase is she and what protocol will you use. Okay. So if she is in the early follicular phase, well, no problem. Let her be on day 2, 3, 4, 5, 6, doesn't make a difference. You just start off your stimulation. Okay? If she's come here, so what is here? Here there is going to be one dominant follicle, 14 millimeter. The rest of the follicles are small, and few follicles could be 8 and 9 millimeter as well. So if you really start the stimulation, you won't be able to wait for 5 days. Before that, a few follicles will touch 12 millimeter, E2 is going high, and your premature LH surge will take place. Because it is due for a surge anyway. And so you wouldn't know when to add your antagonist. You will not be able to precisely time your antagonist. So if the client comes to me between, let's say, 8 to 14 days, I'm a little hesitant to start off my stimulation. Rather, what I will do is, I'll just put the patient, I'll tell her, okay, is the follicle beyond 16 millimeter, I'll see. If the follicle is beyond 16 millimeter, I'll just give her a GnRH agonist trigger. She takes a trigger, the follicle, LH goes up, follicle ruptures, it comes in luteal phase, and I start my stimulation. That's one thing I can do. Okay? We'll discuss this also but that is the random start, that slide is in random start. Okay. But I don't think that slide is here. Okay, I'll take you to that slide. Okay, I'll take, let's understand this, and I'll pause this presentation, I'll go to that, and then I'll come back to this, so we can cover up both the things together. Then suppose it is, so I have electively given GnRH agonist trigger, and now I come here. Can I start a stimulation here? Yes, I can start. But the problem when you start stimulation in the early luteal phase is, these follicles, these three are atretic follicles, because they were dominant here. They tried to be dominant, but could not become dominant. So when you start stimulation, only 1, 2, 3, 4, these 4 will grow, these 3 won't. So you look at a 7 AFC, but after 5, 6 days, you will only see 4 follicles growing. Okay? And you can go in this. This is the ideal phase to start your stimulation. You got this properly? Huh? Now, let me just stop this and I take you to the random start. Okay. We'll do some 3-4 slides and we'll go back to that presentation. We'll finish it off. So this is, I'm talking to you about late follicular phase start of IVF cycle. Okay. So this is the late follicular phase, wherein you have a 14 millimeter follicle. This is day 7 to 10, and then you have some smaller follicles also. Don't bother about the LH surge here, because that LH surge is not going to affect the smaller follicles, because I told you yesterday it is less than 10% LH receptors. So if the LH goes up, these follicles are naive, they are still okay to go ahead. So there would be a follicle of 20 millimeter which is going to rupture, and with rupture, your progesterone is going to go up with corpus luteum. As it becomes corpus albicans, the progesterone is going to come down. So can you start a stimulation here? Yes, you can start a stimulation. You start with FSH stimulation. Okay? And let this rupture on its own. There is no need to add something. Let it rupture on its own. It's not going to make any difference to these follicles. They will keep growing, and you can add an antagonist. Since it's a corpus luteum, it's an LH predominant and progesterone predominant this. So chance of premature LH surge is not there. Only as the progesterone level starts dropping down, you will have to add an antagonist. Okay. Now, you are not able to monitor this cycle that closely. So a lot of us keep doing fixed anta in spite of this. We will do a fixed anta because all our studies are saying fixed anta is better. So in this particular cycle also, you can still do a fixed anta, and not to think more about when to add antagonists. Don't ask questions. Best is to do a fixed anta, you're still doing good. This is the second way. So you have day 1 to 6, patient never came to you. Patient came in the late follicular phase. As I told you, give a GnRH agonist trigger. The GnRH agonist trigger will take the LH up, down. The trigger effect will be over in 72 hours. The corpus luteal, there is a complete elective luteolysis of the corpus luteum. So wait for 4 days and then start stimulation. So do you need to add antagonist? There is no need to add antagonist till the time you are in the luteal phase. Only let's say after 4 or 5 days she gets bleeding because you are given a GnRH agonist trigger. She may get bleeding, menses, and you have started stimulation. You may have to think adding anta later. HC goes in the follicular phase, because then premature LH surge can take place. Again, don't think much. You add a fixed dose anta, you still are good. And this is a study by Antonio Lemaca. He says that since there is no RCT published on when to add anta, in his practice he gives antagonist, starts antagonist on a fixed anta, and you're still right. So I'm just telling you, you can start stimulating in the late follicular phase. This is another way of doing it. You don't give GnRH agonist trigger, just start it at the first slide, or you can give a trigger and then start off. I would prefer giving a trigger and starting off, because that follicle just disappears. I've completed the trigger part of it, and then I can start stimulating. So alternative, so let's say you're starting a stimulation here, very few follicles, and this will go on, and you, instead of giving thinking about when to give antagonist, fixed dose, flexi, etc., just put PPOS. Start your stimulation, add a micronized progesterone tablet, 400 milligrams at night, or medroxyprogesterone 10 milligram once a day, or dufaston 10 milligram, depending upon your choice. Do a PPOS. You don't have to think then when to add antagonist, and you can carry on the stimulation, give a trigger, and go ahead. That is the other way of doing late follicular phase stimulation. So this is that Antonio Lamaca statement in 2018 in Modena. He says that if the patient presents with follicular phase with a dominant follicle larger than 14, we wait for spontaneous ovulation to start stimulation, or agonist administered as a trigger. So from this, I prefer doing agonist trigger. So in our practice at Sunanda IVF or Jahangir, wherever we are, we stick to the science as strongly and as closely as possible. So we read an evidence and we implement the evidence. So most of our protocols keep changing every 6 months. Every 6 months we have introduced something new or the other, because we keep reading the evidence and we start maneuvering that. But that has made so much of difference. We are not having a fixed attitude on something. We are flexible and we can maneuver our way through properly. Now, so the patient can come with a corpus luteum. She has come in early luteal phase to you, kept 2 lakh rupees in front of you, and you sloped and started stimulation. So you are starting a stimulation with a good LH, a high progesterone. Because of high progesterone, GnRH activity is low, and you can start stimulation. Just start stimulation, and you can add an antagonist, or you may not add antagonist. You may not need an anta. You can just start stimulation, nothing to it. But the problem is, those few larger follicles here, they will not grow. Those atretic follicles won't grow. So the AFC, what you see here, and AFC, what you will see at the end of the stimulation, the follicle output rate will be less. That is your expected. So I generally am not in a great favor of starting a stimulation in the early luteal phase. So this is my preferred choice. So you go to the corpus luteum. I will wait for the, some days, go into the late luteal phase and then start stimulation, because I can get a best synchrony at this point. There's another choice you people can do is, you have a corpus luteum, you have this asynchronous follicle, you give an antagonist injection for 3-4 days. Okay? Do give an antagonist injection. If you give antagonist injection for 4 to 8 days, 3-4 days here, you are taking the LH, progesterone, everything down. You are creating an artificial late luteal phase, isn't it? By getting the FSH-LH down, and then you start stimulating further. So this is the way. So I'm just giving an example of you can start stimulation on any day of the cycle. And I told you yesterday that dissociate menstrual cycle from ovarian cycle. The moment you learn to dissociate the two things, your stimulation is far, far better. And late luteal start is ideal. I feel this is an ideal start. You start somewhere here. Follicles, anter-follicle count. You can add an antagonist as she crosses over. And higher dose stimulation, an ideal time to start, because you're syncing with a natural FSH rise. So late luteal stimulation is almost a hallmark at our place. And sometimes I will give late luteal, I'll see the follicles, I may give an late luteal estrogen, take her over after 8 to 10 days, and then start stimulation. One of them will be done. Okay? So I'm not going to the evidence papers. I'll go back to my endocrine monitoring. I'll halt here. Any questions till now you have? But this could go a confusion, that's why. Any questions here?
What hormonal level you expected? You will check a hormone before starting a random start mostly. You say that random start usually starts in the late luteal. Will you do a hormone profile? And if the decision changes, if suppose the patient is not in an urgency rather than on day 2. In that case, what hormonal profile you will do and what do you expect and how will you change the management based on that?
So this happens very commonly to me. The client comes and we said we want to go with IVF. The client agrees and says when should I come next? So I always tell them to come 4 to 5 days prior to the expected cycle. And then I do a sonography, and if I see a good synchrony of follicles and the corpus luteum is already crumpled up, I will just start the stimulation.
No need to do hormones.
No need to, because all the baseline hormones are already done. Okay. Now that day she says, well, doctor, I am not able to your pickup. Then we always explain a timeline. And the timeline is coming such a, let's say her pickup comes on a particular day and says, well, doctor, we are not available. There's a marriage in my family. Can we postpone the pickup by another 3 days? Now I put estrogen 2 tablets to her, take her for all the time with estrogen and time it in such a fashion that I can schedule her pickup after her marriage ceremony, etc. So we highly promote in our practice, that's one of our marketing point, that don't worry, we will schedule all your pickups on Saturday, Sundays. Like donkeys work on Saturday, Sunday, so I work. So we always tell them we can schedule. So all the working women are more than happy if they are scheduled on a Saturday pickup, because they can take a Sunday holiday, start working on Monday again. Okay, so it's completely maneuverable. Everything is scheduled. There is no need to schedule only because you are going for an Ashray conference. You can schedule every cycle. So in the University of Lille, it's a practice by Dido that they don't have any pickups on Saturday, Sunday. So they schedule every patient. Some patient is scheduled with 1 day of estrogen, some on 2, some on 10 days of estrogen also. And they published a large retrospective analysis. They said scheduling does not affect the results. In Spain, Garcia Velasco is he is a bicyclist. It's a cyclist actually. Like he does south of French tours and everything. So with all this athletic schedule, he has to schedule the whole practice. So giving OC pills for 12 days or giving estrogen pre-treatment is very common in their practice. They have published their reports also that our scheduling has not affected the live birth rate. So you can do that. You understood. So we don't do any tests there. We just start off.
Sir,
Yeah, they will require a little. What she says is correct.
yes, sir, it is very synchronous now. Why don't I start Progainova and get them to day 2?
You can, that's what I'm telling you. You can do that, but it's not a must to do that. It just makes you happy you started everything on day 2. That's what on the very first day, before embarking IVF, you dissociate the menstrual cycle and ovarian cycle. So the client doesn't feel any awkward. Client says, well, you are okay with it, doctor? Go ahead. There's no reason. What I'm telling firstly is, there is no reason to go to day 2. Come out of that psych totally. We are not doing any jugglery. Rather, if you make a practice to start every stimulation on day 2, you are inviting asynchronous. Chalo, mere saath, let's become asynchronous. We are not doing anything to that. If the moment you start your stimulation, all your stimulations on -4, probably you are avoiding a lot of asynchrony there. That's what I want to tell you. So
Because
we have to
E2
take
is
this
a
out from our mind that day 2 is a must. Like day 2 is bad. -4 is best. Convince that, and these things are more physiological with nature.
Because E2 being a weak suppressor of FSH may not suppress all FSH and wait till day 2. That is the reason, sir.
I didn't understand this.
Sir, E2 is a weak suppressor of FSH. So it
Why you want to suppress FSH anyway?
no, actually to get it to day 2.
Why day 2?
Yes.
Why day 2?
Okay, sir.
Day 2 is bad. If you get it ingrained in your brain, then that makes the life simple.
Okay, sir.
D2 is good only if you want to do a fresh embryo transfer cycle. Still, even if you want to do a fresh embryo transfer cycle, still you can start a stimulation on -3 day and do a fresh embryo transfer cycle, because you're still going to go into the follicular phase anyway. She's expecting her cycles in 3 days. Still you can do that late luteal. That's not a problem. Okay, some pre-treatment. Now, people will take some pre-treatment or the other. People are in fashion. In my practice, but for estradiol valerate, I don't give any pre-treatment to anybody in my practice. So some people would have taken combined oral contraceptive pills. What happens after combined oral contraceptive pills? So the earlier studies on, let me tell you the evolution of combined oral contraceptive pills, how it ever started. The whole IVF, especially antagonist protocol, came very high in Belgium under Paul Devroy. And all Paul Devroy students like Colibianakis, your Simon Bror, or George Grisinger, everybody got, Human Fatemi is also Paul Devereux's student. All of them got invitations from Cyprus and Macau and all these countries to do IVF. So they had to do batch IVFs. So they had to put everybody on OC pills and withdraw. And then they realized our OC pill cycles are not giving us good results as they get in Brussels. Okay, and that made us think that made them publish reports on OC pill pre-treatment. So these reports came from a lot of people. Kolibianikis published, Sredin Diorin published, and they said whenever you give OC pill pre-treatment, your fresh embryo transfer pregnancy rates are low, and you face also more miscarriages. So they blamed it on the egg quality, competence of an egg, maintaining low LH levels, etc., etc. And but there's no certain conclusion. And George Grisinger published a small paper. He says the answer of OC pill pre-treatment is in the data itself. He said, why we are not coming to a conclusion? Because the data is completely heterogeneous. He said, people have used 50 microgram of ethanol estradiol containing pill. Somebody has used 30 microgram. Nobody knows how much of progesterone, desogestrol. Somebody has used 11 progesterone. Somebody has given 40 days of OC pill. Some cycles have received 10 days of OC pill. So it's all scheduling and pre-treatment was mixed. There was no objective to that pre-treatment. Some of the patients were pre-treated for scheduling, some of the patients were pre-treated for their PCOS features or some stupid features or something like that. You got it. So the data was so heterogeneous, that's why he said we are not coming to a conclusion. So all that data, so Sredin Diorin again published a whole systematic review on OC pill pre-treatment. She categorically said that giving OC pill pre-treatment decreases live birth rate, increases miscarriages in fresh embryo transfer cycle. And even if you do frozen embryo transfer cycle, the live birth rate is okay, but miscarriages still persist. So they blamed OC pill pre-treatment to giving rise to a low competent egg. I strongly believe in this. Have you heard of post-pill amenorrhea? Or giving OC pills, and that would decrease that decreases your fecundity rate. So there is some affection of the hypothalamic pituitary ovarian axis which persists for a little longer time. Little longer ka definition is not known. 15 days or 15 months, that we really don't know about. So after OC pills, if you stop, Grisinger only did studies of how much time for the FSH to come up. Because everybody said if you go OC pill treatment, stop OC pill, start the stimulation on day 2, and you achieve synchrony. But they realized they don't achieve synchrony. So the Grisinger said they did FSH levels on every day after stopping OC pill. In 48 hours, the FSH goes up. But the periods don't start in 48 hours. Periods start after 5 days. So in 48 hours, the FSH goes up. After 5 days, you start on day 2 stimulation. So asynchrony is achieved. So OC pill pre-treatment cannot prevent asynchrony in antagonist cycle. But OC pill treatments can prevent asynchrony if you start stimulation 48 hours after stoppage. You stop OC pill today, Sunday, Tuesday you start your stimulation. She may get bleeding on Thursday or Friday, and you can go ahead. People do that way, and they still do a fresh embryo transfer cycle. It is possible. But to do a fresh embryo transfer cycle with a late luteal start, you should cross over the menses properly. ऐसा नहीं कि मेंसेस कल और 4 ही दिन मिले and then you are doing an embryo transfer. No, that's not possible. You get nice 8 to 9 days of estrogen exposure is necessary. So you may have some missed cases there. But problem with OC pill is LH will be suppressed, and LH need not recover in 48 hours. LH may take 5 days to recover. In a subgroup of women, LH may take as high as 7 to 10 days to recover. And there is no way you can identify that subgroup. Now look at this. You're given OC pill pre-treatment. You started stimulation after 5 days of washout period. Whether she got period, she did not. And then you started stimulation. In a subgroup, the LH has not recovered. So LH, because of OC pills was low, it has not recovered. You start with stimulation, GNSAF goes up, so the LH still is low. On 5th day, you're at fixed ANTA, LH still is low. So through the cycle of stimulation and pre 7-8 days, the LH is low, and I always told you, you need a good LH level. And now she will suffer with her fertilization rates, metaphase to oocyte, everything will suffer. Even the embryo formation, the empty follicle syndrome will be higher, etc., etc. You got it? So in my practice, as I stand today, absolute no-no for OC pill treatment. But some of you could be scheduling or batching your patient. Can you use OC pill? Yes, you can use OC pills. Use low estrogen OC pills. Dronis, I would prefer using something like Dronis. Your ethanol estradiol 20 micrograms, 20 with whatever drospirenol. So use 20 microgram wala pill. Give it not more than 12 days. That is a Spanish study by Garcia Velasco. That giving 12 to 14 days is okay. with a low estrogen, it does not affect the results. So you can do batching with OC pills. But in my practice, I don't do. So you will have LH low, E2 progesterone, both will be low if you do OC. Yes.
So adding the LH surrogate won't help with this, like menopur or like HMG?
Very right question. But menopur is added during the course of stimulation. You need a LH pool, and you need a good pre-treatment LH pool, and you need a good treatment LH tone to have a better outcome. So menopur will give the tone. The pool is not there. You understood that?
Yes.
Okay, that's why that wouldn't make much of a difference. You understood this? So OC pill is something, yeah. But one thing I must tell you, that post OC pill, you will not give recombinant FSH alone stimulations. No, don't do that. It's better to use menopur. So I will agree to that part of the story, because LH is already low. At least menopur will give you some amount of LH tone there. Estradiol, this is my favorite. I prefer giving 4 milligram. Should you give 4 milligram or 6 milligram? If you are giving late luteal estrogen, I give 4 milligram. Sometimes the client comes on day 2 and says, I will start my stimulation after 8 days. Ganpati ho jane do. Then I will put them on 6 milligram to 8 milligrams of estrogen in the follicular phase. And then the last pill is given, let's say, taken today morning. They don't take doses today, afternoon, evening, and next day morning I start my stimulation. So that is FSH 24 hours. And the synchrony is very good. The most beautiful part of estradiol treatment is your LH is high. So you are creating an LH pool, unlike OC pills. So suppose it happens that you want to start stimulation today. You do an LH activity test, and LH level comes 0.5 suddenly. So don't start your stimulation. Put the patient on Proguanova 6 to 8 milligram for a period of 8 to 10 days. Measure LH again. Now the LH has gone up because of estrogen. A high estrogen level in a body will tell the pituitary positively to put LH up, but not to a surge level. Even it goes to a surge level, let's say LH goes to 20 because of your estrogen, there is no follicle to act upon. So LH remains as LH only. It doesn't make any difference to the follicle down, because there is no follicle, big follicle to act on. They're all small follicles having less than 10% LH receptor, so it wouldn't act on those follicles. So this is the favorite treatment. How many days of estrogen? Any number of days. The studies are there till 28 days of estrogen pre-treatment. Doesn't make a difference. And there are studies on fresh embryo transfer. So you're chill about it. Don't worry. Agonist, antagonist. You can do an agonist. There is something called a stop agonist protocol. That means 7 days prior to the expected menses, you give start agonist every day, leuprolide 0.5 milligram every day for 8 days, and she will get menses. Moment she gets menses, stop your leuprolide and convert to a typical antagonist cycle. The start stimulation. You get a very good synchrony, no doubt about it. There are loads of papers published on stop agonist protocol by Raula Orivito, and they use it for poor ovarian reserve. But don't go by that. Poor ovarian reserve needs to be subcategorized. Like you will easily understand, let's say poor ovarian reserve is an AMH less than 1.1 by Posidon group criteria. A patient between 0.8 to 1.1 will behave differently from 0.5 to 0.8, and less than 0.5 and 0.3 will behave differently. Am I right there? Isn't it? So suppose you uniformly use stop agonists for poor ovarian reserve, and you have 5-6 clients who are having an AMH of 0.4 and 0.5, you put on stop agonist, you are depressing them. It may not work well. So for a reasonably good poor ovarian reserve client, agonist stop will be. Do I use it in my practice? Absolute no. Since I have found estradiol, I have stopped using agonist. So stop agonist is only for me, it's just a theoretical discussion. I don't use it at all. Antagonist, an absolute no for antagonist as a pre-treatment. Because LH pool mein kharab karna chahta hu aapka, and then I will start my stimulation. It is absolutely anti my ethos of stimulation, because I want LH there, and by giving antagonist, I'm taking the LH out and then I'm starting stimulation. It's absolutely reverse of my thought process. So I wouldn't give this. But you will see a lot of people, even a lot of big consultants in India saying that, well, you give antagonists. If you look at the papers by Christoph Blockhiel has been published on giving antagonist pre-treatment. Well, they have said the metaphase 2 oocytes are good, but they used it in their normal patient. They used antagonists for synchrony. We have borrowed that thing from them, and we are using antagonist for patients who have polycystic ovaries with high LH. But they never used it for that indication. We just borrowed that thing. and now you're suppressing the LH. So you're decreasing your LH pool and starting up. So I'm not happy with antagonists. I still feel E2 pretreatment was the best. Sometimes I do feel that giving E2 pretreatment should have been much, much better than doing long agonist protocol. What does a long agonist protocol do? It suppresses your FSH, so all the follicles get synchronized. What will estrogen do? It will suppress your FSH, so all the follicles will get synchronized. Agonist suppresses your LH also, so harms the stimulation later. E2 will not suppress your LH, will create a good LH pool, so your stimulation further is better. So I feel instead of using agonist and antagonist, use E2 as your pretreatment. I'm very happy with that. So only estradiol pretreatment has good LH pool to start with the stimulation.
So,
Yes.
like I want to confirm this. If having a pre-treatment with estrogen is similar to having a residual follicle, am I?
Absolutely. Absolutely. Okay. Residual is God's gifted estrogen pool. Yeah. So suppose you have a low start day LH, 0.51, so or less than 1. Definitely the risk of empty follicle syndrome with agonist trigger is pretty high because the pool is not there. So advice would be start Proguanova 6 milligram to 8 to 10 days till LH will increase and then start the stimulation. Okay. So FSH will obviously go down with Proguanova, but anyway you're going to give exogenous FSH, but LH will be good and pool to start with. And this slide, I think yesterday, you asked this question only. Yesterday, Dr. Sharif has gone through this particular slide, so I'm not going to go through this. Let's come to day 6 of stimulation now. You understood random start properly? Okay, you understood all that thing? Huh?
Is there any subpop patient who will escape from the FSH suppression by Proguanova, like say old age?
Yeah, so women who have a very high FSH, like ones who are occult POI, giving estrogen may not suppress them that badly. That can happen, But most of them will go down, but not that badly.
In that case, will you add antag in the luteal along with Proguanova?
No. See, again, coming to, I'm interested in ovarian follicle. I'm not interested in the FSH coming down. I want the whole ethos of giving E2 pre-treatment is to have a good synchrony follicle. And that is achieved by the FSH coming down. We have an old lady with an FSH of 24. Even if the FSH comes down with estrogen, but there is no follicle there. There's no follicle. There's not enough granular cell. There is no inhibin there. Because there is no inhibin, FSH is high. So it's a pituitary story. We don't want to alter the pituitary story here. There is no pool there. So we are concerned, your estrogen is not going to generate a pool. There is only one paper onto that notion of, they have not used the word occult POI. Occult POI is the one where FSH is between 20 to 30, and these ladies could be getting cycles very, very irregularly. Now, in these particular women, if you give long-term estrogen, see their ovarian wave will be once in a while. Giving a long-term estrogen may create 1 or 2 follicles, AFC will be seen, and then you can start off. But it is real long-term, maybe 40 days or 45 days. But again, I'm just quoting one study. I've read only one study on that. There is no replication of that particular study. Yeah, that would be. The best would be for a POI patient, as we were discussing, just keep them on monitoring of AFC. The moment an AFC follicle appears, now take that follicle up with giving RFSH injections or HMG injections, give a proper trigger and aspirate that follicle. But the problem is we cannot tell when that AFC will kick off. It may be once in a month or it could be once in 3 months. So the lady has to have that kind of patience and saburi so that she can face it up. There is no way we can create that follicle. There is a way to create. The other way would be giving them clomiphene for a long time or giving HMG injections for a real long time. So their FSH is already 20. Make it 30 by giving your FSH injections more, and then see if one of the follicles can kick off. But again, we have to keep telling them again and again, I don't see a follicular pool, I don't see a follicular pool, I don't see a follicular pool. That we have to keep telling them all the time, making them sensitive about it. And they are telling, do something, but unless we see a follicle, we can't do anything to that level. So what has happened on day 6 of the stimulation is, what is this? This is like the LH has come down, I told you. The LH has come down, the yellow line, because of the gonadotrophin surge attenuating factor. The FSH injections or HMG injections you're giving till day 5. So your FSH is going up and follicles are growing, that's why your estradiol is also going up. Okay, so on day thing, this is what happens. The GNSAF will stop its expression once the follicle crosses 12 millimeter. So once the follicle crosses 12 millimeter here, FSH is high, estradiol is high, but GNSF is not there, and since there is a risk of premature luteinization, LH premature LH surge, not lutein, LH surge, and that's why you start giving antagonist every day, and that antagonist will decrease this LH further. In the later part, some patients will have an escape of LH. We'll come to this, but this is what happens. Your FSH and estradiol will keep going till the end of trigger. Estradiol will keep going, but the LH will be down all the time. Initially because of GNSAF, later because of the antagonist injections. So expected E2 should be beyond 100 picogram, LH lower than basal, FSH higher but not measured. We don't measure FSH on day 6 of stimulation. LH should be low. The E2 should be high. If the E2 is less than 100 picogram, cancel the cycle. You have not reached the FSH threshold. High response E2 beyond 500 picogram or 15 or more follicles beyond 10 millimeter seen. You always thought of a ferritium transfer. Suddenly on day 6 you are feeling this picture. You tell her, well, I'm going to plan an agonist trigger and freeze all for you. So change of decision can take place on day 6 after doing these tests. Hypo response is defined on day 7 of stimulation, at least 6 follicles between 6 to 10 millimeter, no follicle of 10 millimeter or more, E2 less than 180 picogram. And this is a study done by an author in long protocol. He said you can define a hypo response, and if you define, you can abandon the cycle and go with a higher dose, rec FSH, etc. in the next cycle. Again, asynchrony you created. That's what I'm telling you. Again, these are two thought processes we need to come out of mind. Halfway through increasing the dose will always create problems. Okay, rather give high dose right from the start. Because you are starting the stimulation on day 6, the follicle will max go to 12 or 13 millimeter on the day of trigger. Anyway, that follicle is not going to yield a oocyte, but you will just increase the cost of treatment. So might as well cancel and start with a higher dose next time. There's no point. Or you start with a higher dose and counsel the client, the stimulation starts today and it will last for 14 days from today. But so many injections the client won't take. So day 6 decisions are individualized. So in my practice, madam, my fellows will be more telling you, we hardly see any halfway through decision changes. Why? The secret of that is Gonalef, Menopur, drug we choose, starting 300, nothing less than 300 dose. Somebody we gave 225 Menopur recently, isn't it? But she was a very good responder. But for a long time I gave 225 Menopur to somebody, otherwise it's always that way. Day 6 decisions are individualized, no follicles beyond 10 millimeter in normal responders, 2 follicles of 10 millimeter, step up the dose. Now this is a very unique situation. So you suppose in a normal responder patient, if you don't have a follicle of 10 millimeter or more, you can just say, well, the recruitment is not taken place, cancel the cycle, let me start with a higher dose next time. But if there are just, this lady is a very poor ovarian reserve, there are only 2 follicles and both the follicles are just 8-9 millimeter, you can step up the dose because no new follicle is going to form, only these 2 follicles are going to grow. You got it. So here in a step up is possible. You're not going to create asynchrony because there is no other follicle to create a asynchrony only. Only these 2 are the ones who are growing. So that's okay. No follicles beyond 10 millimeter in a PCOS, don't think it is bad. It is still good because they're going to take some time to respond. So continue the same dose. There is no need of step up also. E2 less than 100 picograms, no recruited follicles, you just cancel the cycle. This is a very beautiful paper, and once we read this paper, it really made so much of changes in our practice. LH level in antagonist administration day as a predictor of reproductive outcomes in women with normal ovarian function. So what they did was on antagonist day, they just did an LH level, and they looked at the blastocyst rate, ovarian response, etc. And look at this. So this is on the LH on an antagonist day, day 6, and this is the number of oocyte, and this is the number of blastocysts. If the LH on the antagonist day is higher, so 7.5, 10, number of oocytes is more. If the now LH is better, the number of blastocysts are more. So again, I'm coming to the same story. You need a good LH pool to start stimulation, and you need to maintain a good LH tone during the stimulation. Very, very essential to maintain a good LH tone. Like Menopur, I gave yesterday also, I'm just repeating that example. You give 5 days of Menopur, HCG level goes to 3 or 4 MIU. Okay, because Menopur contains HCG. 1 HCG MIU is 7 MIU of LH. So 3 HCG means 21 of LH, but still you get good output, live birth rate is good, everything is good. So LH ceiling has no meaning. You maintain a good LH tone. That is the secret of success. So LH levels may be used as an indicator for time of antagonist administration. So this is a beautiful paper. And this paper also intrigued us. So nowadays we do very less fixed anta. We prefer doing, it's 50-50 I would say. 50% patients go on fixed anta, but most of them on flexi anta. We prefer not giving anta as much as possible. So what they did was they looked at the flexi protocol, and they looked at the day 8 LH levels, and they say if the LH level is less than 4, don't give antagonist. If you antagonist, you're suppressing the LH level. It's already 4, it's less. On top of that, you will over suppress it, and your output would be affected. Only when the LH level goes beyond 8, you start adding antagonists. So it's a every 2 days you just keep doing LH levels and take a decision. Well, that is possible. And again, this paper, this way of thought process will make you maintain a good LH tone, and hence you will have a better outcome.
So Menopur is doing that function. Why don't we follow it?
Yeah, we can, that's all. If you use Menopur, no questions asked. It's like golden thing, no doubt. Low serum LH during ovarian stimulation with GnRH antagonist protocol decreases live birth rate, this is what is proven. So LH less than 4 MIU, low rest. So this was defined as low, and rest was defined as high LH group. Women with low LH MIU through stimulation may decrease pregnancy rate due to antagonist use. Women who have lower basal LH may be excessively suppressed. So be careful in your fixed antagonist. This is what we learned recently also. Low LH affects fresh ET also, cumulative live birth rate and fresh and frozen, etc. No effect on the first frozen therapy. So is serum LH a biomarker of good COS cycle? My answer is yes. So there's nothing wrong in doing LH levels and titrating your antagonists. And there was one paper I read, I think sure you would know it. They titrated up depending on the LH level, isn't it? So till LH level 4, no anta. 6 or 7, they added half dose anta. 0.25 ka bhi half dose. And level between 8 and more, they added 0.25. And level beyond 12 or something, they added.
One group they didn't add that.
ऐसा कुछ तो था, yeah. So you can titrate it, but again, you need to call the client very frequently. So what should be my take-home message? My take-home message is don't be adamant in doing fixed antagonist cycle. Do a LHE2. If the LH on day 6 is 6 or less than 6, don't add antagonist. Just call her after 2 days. Again, do an LH level. Now your LH level is started going beyond 8. Yes, you add an antagonist. Okay. Do you need to add a very strong antagonist? No, I prefer adding nowadays elagolix tablet. Just add 150 IU of 150 milligram elagolix tablet, just one tablet a day. Will be a moderate suppression. We need a good LH level. It should not surge. That's all we want. So that is something which can use. Sharyu doesn't use elagolix much. She uses low dose progesterone. So she starts sustained 400 milligram orally at night. And that's also a good, it will be a moderate suppression of LH. You will maintain a good LH tone. How is the antagonist action? This is the way antagonist action is there. You give antagonist, in 2 to 4 hours, the LH will drop. And it will take 16 to 24 hours the LH to recover. So Shahar Cole et al., he did the orgalutron study, which was done in 1996. And he published a beautiful paper in 2021. And he said there is a subgroup of women who require LH in stimulation. What he did was, you give antagonist. He measured LH activity on day 6, gave antagonist, and before the next day of LH antagonist injection, he did LH again. In the women who had recovered 50% of the LH activity, he did not add additional LH. But there are subgroup of women who do not recover the LH to the 50% of the day 6 level. He said these are the women who maintain very bad LH levels and will need LH supplementation. You got it. So the whole answer, instead of putting all the brains, why not, just give Menopur to everybody and you'll be through. What about trigger day hormones and trigger choice, OHS prediction, etc.? I'm not going to do much on this. So on a trigger day, estrogen is the hormone which predicts the OHSS. Okay, so the estrogen is the area under curve is 0.95, very highly discriminatory. So if the estrogen is beyond 300 picogram, or 17 follicles beyond 12 millimeter are predictions. So you can use a loop-right trigger. If there is a hypothyroidism, patients will have more estrogen, low, it's like low thyroid hormone stimulates the FSH-LH with TSH. Low thyroid, you will be more TRH secretion. TRH secretion will not only stimulate TSH, but also endogenous FSH-LH. That's why the estrogen levels are very high. Even low BMI patient will have high estrogen levels. I'm not going to go through this paper. This will unnecessarily confuse you, so I'm not going to go through that. I'm forgetting this. Yeah. So high responder patient, more than 15 oocytes, progesterone level 1.8 on the day of HCG trigger, still has good live birth rate, like a normal responder in patients when even if you do fresh embryo transfer. So I told this yesterday, again repeating it. Progesterone on the day of HCG is bad. We don't know what level and what estrogen level it will make it bad. So higher the estrogen, higher the response, you require higher progesterone to make it bad. Lower the estrogen, lower the response, even a slightest of progesterone will make it bad. So poor ovarian reserve, your progesterone is 1.2, don't do fresh embryo transfer cycles. PCOS, progesterone is 1.5 and you want to do a blastocyst transfer fresh, you can do it if you're, but it's not my practice to do fresh transfers. PCOS is all agonist trigger and freeze all. See, look at this box. What is this box of? This is progesterone concentration and live birth rate. See, if the progesterone goes beyond 1.5, the live birth rate comes down. But what author focused is that even if the progesterone is low, the live birth rate is low. Okay, and that's why he has made a conclusion like this. Like, shall we give progesterone supplements in low range when the progesterone on the day of trigger is very low? Can we give? No, it is too dicey. It's only one paper like this. So it's too confusing. That's why I not put it across. Yeah. I always kept telling you, having a good progesterone level on the day of trigger assures you good oocytes, and this is the paper for that. Okay, do we need to measure progesterone in oocyte donation cycles? You're not doing fresh embryo transfer to them anyway, but do you measure it? So what is the data? As the progesterone level increases, the top quality embryos are better. So even in egg donation cycles, if the donor has a progesterone of 0.5, you can delay the trigger by 1 or 2 days, continue stimulation. Okay? And then if the progesterone level goes up to, let's say, 1, 1.2, give your trigger. Your oocyte quality will be far better. Measuring trigger. I'm not going to go through measuring, but she will take it up. You understood? No, 1 minute, one more. Yeah. This is about PPOS. If you go HMG through the stimulation and you give medroxyprogesterone through, that is progesterone prime ovarian stimulation, there is no point doing any hormonal test anyway. You are not taking any decisions here. So day 6, no tests unless you are doing the flexi policy PPOS. We don't do flexi PPOS. A day of trigger, obviously, you will do LH and E2. There is no need of doing progesterone levels here. And only thing is, if you give progesterone, it is said that the LH is suppressed more. So if you give agonist trigger, you have to measure the trigger, because sometimes agonist trigger doesn't work in PPOS very well. How to achieve synchronization? Okay, synchronization, the secret is you should not have an FSH rise prior to start of the cycle. So you can use stop agonist, ocipils or estradiol, which I told you. If you give a washout period, that's a problem. Washout period again causes asynchrony. So you have to decide on how much of washout period. E2 synchronize is better because high LH. Stop agonist will be it will suppress, it will have low LH FSH. Ocipils, 12 to 14 days is okay. So any of these is okay. My preference is to E2. Okay, any questions on this?